And Dr. Longden, he's come. He have just graduated from dentistry university, and please with your topic.
Thank you, Dr. Hai, for the kind introduction. Good morning, distinguished professors, doctors, colleagues, ladies and gentlemen. My name is Dr. Roy Ong, and this is Dr. No, and we're from Adelaide. Thank you for the privilege to present on the topic for successful outcomes in facial trauma surgery. This is just our own personal experience, and we hope to share what we learned along the way. So the primary goals for facial trauma surgery is not just to unite bones, but to achieve good restoration of the volume and function. So in this talk, I will focus on three main fracture types: the orbital fracture, mid-face fractures, and also condylar fractures. Starting with orbital fractures, the way I think about it is three main approaches. One are the indications for immediate intervention to protect vision and other functions. What are the functional indications, and what are the aesthetic indications? So a landmark paper by Bernstein describes several indications for immediate intervention. So the first one is an entrapped muscle, or what we call a wide-eye blowout fracture, where the rectus muscles is trapped, and without immediate intervention, the rectus muscles can be necrosed and the patients can get permanent double vision. So it's important for us to intervene soon. The other indication is a non-resolving oculocardiac reflex. What happens is patients can get bradycardic, heart rate goes down, they have nausea and vomiting, and in severe cases they can lose consciousness. They can have syncope, and even more severe cases they can go into cardiac arrest. So in these cases it's important to relieve the pressure from the orbit. Other indications described by Bernstein include severe hypoglobus, where the eyeball, the globe, sinks into the sinus, and ocular globe emergencies like retrobulbar hemorrhage, orbital compartment syndrome, and orbital apex syndrome, where the pressure of the orbit can cause ischemia to the optic nerve, resulting in permanent loss of vision. So in all these cases, it's very important to go in to do the operation as soon as possible to prevent these long-term complications. Diplopia, also known as double vision, is a common functional indication for orbital surgery. Often in our clinical practice, we just get the patients to look at our fingers and see if there's a double vision. However, there's a very good objective method called the hash chart that we get our colleagues to assess for us, and this allows us to look objectively specific muscles that can be affected, causing the double vision that patients experience. During the surgery, we can also do a forceduction, where we actually move the eye with an instrument to see if there's tightness in specific directions when we try and move the globe. And after the surgery, it's also important to encourage physiotherapy to the eye. So tell patients to look up, down, extreme gaze, so that they can exercise the eye muscles as well. One very common aesthetic indication for orbital surgery is globe now position. So there are many ways that the globe can be in an abnormal position. So one is the eyeball can sink back, also known as anophthalmos, and the eye can sink down, which is known as orbital dystopia, and also other associated issues like helicanthus or hypertelorism, when the eye can move apart. And there are many ways to assess it, not just visually using a ruler, but also using something called a Hertel's x-ophthalmometer, which is here. So the reference line is on the lateral orbital rim, some cases when you have a fracture of the lateral orbital rim, we can use something called a Lugol's exophthalmometer as well, where we use the reference lines from the superior orbital rims as well. So ultimately, a lot of the globe malposition issues come from loss of the orbital floor leading to increase in orbital volume. So now we have three-dimensional volumetric analyses that allows us to assess the volume of the globe, which I will explain and describe a bit later. So there are many different options in restoring the globe or the orbit. Traditionally, we use autologous bone grafts. We can use cadaveric bone grafts. We can use xenografts. Most commonly, I believe people use a titanium mesh, and they can be stocked, where we bend it in the operating theater. It can also be pre-formed, where the mesh is specifically formed, and there's also other options as well. However, in my opinion, the most accurate way to restore orbital volume is when you can produce patient-specific implants, where the mesh is specifically already contoured to the shape of the complex shape of the orbit. Now with the technology to plan virtually, we can mirror the shape of the orbit from the non-affected side to the fractured side. So once again, this is a patient of mine who has very kindly allowed us to use his photos in an academic setting, so I would appreciate it if you do not take photos of his face. But you can see very clearly that he has quite significant endophthalmos in his eye. He suffered an orbital floor fracture, and this has caused his eye to sunk back due to increased orbital volume. So this is a 3D reconstruction CT scan of his skull, and we can measure specifically what the orbital volumes are. So you can see pre-operatively, there's at least 2,500 millimeter cube difference between the affected orbit and the normal orbit. So this is a post-op simulated orbital volume, and the difference is significantly less at about 150 millimeter cube. You can see in this CT scan, this is where his orbital floor, the fractured orbital floor is, and this is where we plan to put the pre-formed titanium plate. So the red part is where the plate is, the purple part is the superimposed mirrored side from the contralateral or the right side of the orbit, mirrored to the left side. Once again, the purple side is where we have mirrored this orbit, and we'll reconstruct this left side orbit based on the mirrored side there with the plastic titanium mesh in the region. So the next part of my presentation will be with regards to mid-face and condylar fractures. I'll pass it on to Dr. Long.
Thank you, Roy, for the kind introduction. So I'm Long, I'm from Adelaide. So the next part is we're going to talk about the fourth fracture and also the diagonal material complex fracture. For our considerations, we will consider the functional aspect of that and also the aesthetics. For functional, we will talk about trismus, which is limited mouth opening, occlusion, which is how the teeth come together, and orbit, or vision, which was discussed by Dr. Roy in previous slides. For aesthetics aspect, we will talk about facial width, which is the horizontal dimension. We'll talk about the height, which is the vertical dimension, and of projection, which is the width, and which is the depth of how the face is formed. Okay? Functional consideration of trismus. So we have have prismas here. The zygomatic arch fracture can actually impinges on the temporalis muscle attachment, which causes it to be unable to function properly, which causes limited malopening. Malocclusion will happen in the lymphoid fracture. So intraoperatively, so we would focus on intermaxillary fixation to restore the occlusion before we actually fixate the fracture fragment. So why it's only for the lymphoid fracture is because in lymphoid fracture, the maxilla is actually completely separated from the skull base. Okay? For orbit, we already discussed that in the previous slides. Aesthetics consideration. So our focus is to reduce or hide the scarring or the incision. So these are the list of the incision now commonly used in the literature. And also to restore the width, the height, and the projection, we need to look into the vector or the force of reduction of the fragments. And also, if we need to plan for restoring the fracture fragments or plating, we will need to use the vertical and horizontal matrices of the facial skeleton. So intraoperatively or postoperatively CT scan will be useful in this case. So these diagrams show the common periorbital incisions used in zygomatical maxillary complex fracture. So we have here, which is the lateral brow approach, which you have an incision around this area of the eyebrow. These are the periorbital incision, and then this is the lateral upper lateroclasty approach. So basically the upper eyelid. For zygomatic arch fracture, we have two approaches that we would recommend in our presentation. So we have Keen's approach, which is the intraoral approach. So you have an incision in the buccal mucosa, and then you try to access the zygomatic arch intraorally. So in that way, you can actually hide the incision. However, in this case, as you can see, the vector of reduction is almost hard to visualize and it's hard to use. However, for Gillies extraoral incision, so we do that around on the skin, so we have the skin incision, and then we try to go down with the fluorescence elevator. This approach has better vector reduction. However, you actually has a skin incision on the patient's forehead. So regarding the tissue plane of the Gillies approach, so we try to have the skin incision 1 inch superior and 1 inch anterior to the ear to avoid the bleeding or damaging the superficial temporal artery. For tissue plane, we want to stay, so our aim here is to go to the medial surface of the zygomatic arch. So when we actually make the incision, we want to stay above the the temporal fascia, and then we try to stay deep to the deep temporal fascia and superficial to the temporalis muscle. So we're trying to stay on top of the muscle instead of going through it. And also, in this diagram here, you can see the frontal branch of the facial nerve. So in this approach, we would try to avoid damaging the facial nerve. Okay. So in this CT scan, so we have these are the pre-operative CT scan. So in order to restore aesthetics, we need to assess the patient, like how the patient comes in. So we actually have an axial view to show the width discrepancy between the two. So you can also see the natural curvature of the right-hand side, and there's a step over here. Also, we need to find out about the projection, which is the depth. So we actually have the zygomatic arch here is actually dropped down. We can actually have a look at the sinus lining, which is disrupted. Moving on to the coronal view, which is we're going to assess the height of the orbital floor, and also we can also see the width as well. Okay. Post-operative X-ray. So in our literature we found we would recommend using the occipital mental X-ray with the 30 degree or the submental vertex view. Otherwise, we can also use intraoperative or post-operative CT scan as an alternative. Moving on to the mandibular condylar fracture, we have two approaches to fix this fracture: either close reduction with intermaxillary fixation or open reduction with internal fixation. So, according to Zeit and Penn, they wrote a landmark paper that described the four main indications for open reduction and internal fixation, which is the displacement of the condyle into the middle cranial fossa. Second one is the inability to restore occlusion with maxillary mandibular fixation, or lateral displacement of the condyle. In this one here is that the presence of the foreign body in the TMJ that require access and also irrigation to wash out the joint. Other indication include the displacement, the deviation of the condyle on the condylar head medially due to the axillary lateral pterygoid muscle, the shortening of the ascending ramus. So these ones actually reduce the amount of bone that you have for fixation. Okay, so this paper here show us the advantages and disadvantages of the open versus closed approach. So in open approach, patient will report to have a better mouth opening, less pain, better occlusion, and better alignment than versus the closed approach. However, open approach has a risk of facial nerve injury. You guys can actually have a read of the paper, it's really interesting. Second one, so due to the risk of the facial nerve injury, we found another paper that shows the risk of having facial nerve injury for the different type of approaches in the open reduction and internal fixation. So for retromandibular transparotid approach, transient facial nerve injury is 14%, permanent injury is 1%. This approach is simpler to execute. However, there's another one at a lower risk, which is the transmaxillary anterior carotid with pre-auricular extension. This one is a bit more difficult to execute. However, if you see these two here, we have the same risk of permanent facial nerve. So it's up to your preference for the approach that you use. So finally, we have the post-operative management for condylar fracture. Active monitoring to prevent malocclusion is really important. We also need to take into account the TMJ ankylosis. So it's important to keep the joint moving. So we would suggest avoid rigid intermaxillary fixation, as well as encourage condylar movement at 2 weeks after the splitting with soft diet. So no hard diet, no peanuts at all time. So at the end, in summary, successful facial trauma is not just about fixing the bone, but also taking into account the aesthetics, the volume that the bones form. Also, we try to